directly to my slides. These are my disclosure. Can I go up? Okay. So let's go straight to the. I don't know how many minutes we have more. We have 5.
Probably after 25 minutes.
25 minutes. Okay,
Yeah.
very good, very good. So I can go.
We'll finish at 150. 150.
Good, perfect. So 52 years old. This is the guy. Let me see if there is sound. How are you?
I'm doing very well.
How old are you?
I'm 52 years old.
Do you have chest pain right now or no?
No, not right now.
But it brought you to the hospital. Is that right?
Yes, sir.
Yeah. Got it worse since when?
I would say this has been ongoing for about, there's some recurrence. It's been ongoing for about 3 months. Getting stronger this past, let's say, 3 to 4 weeks.
3 to 4 weeks. Yeah.
Don't worry, like 2 weeks ago, I decided to go talk to my cardiologist. I was having a lot of fatigue. I woke overnight, so.
Yeah. So 52. This is you're walking into your office. They call you. You go. There's the transfer. You're sitting, laying down in your gown. You've never seen him before. And he's a 52 years old. Past history, you see like smoking, former daily marijuana, former heavy drug abuse, opioid, chronic opioid after a spinal injury, and he's normal, and he has a long history of stent in February 2023 and in December 23. So I'll show you a little bit of this is February. First time he came in is February 2023. This is my case of last week. Literally, probably 5 days ago. And they treat this proximal LED disease with a stent. 12 months after, and this is December, he came back, and you see the lesion here. Chest pain, non-ST lesion MI, look how tight it was in stentary stenosis, and this is less than a year after. So, and now it's December 24, and he comes back with chest pain and a proximal LED that is still significant. So first question is, how many of you have operated on a single D-tattoo LED in any form in the last 2 months? Good. You know, and how many of you have done this surgery on a single LED with in a minimal invasive, any form of minimal invasive? You see that the hands that raised were mostly the same. That means that a lot of centers, and this is I have this conversation a lot with people that tell me, oh, I want to start a minimal invasive program, a robotic program, but I don't have the patients. I don't see, like there is not anymore LED tattoo LED. Reality is that there is a lot of LED disease, but you don't get it because you don't offer a non-invasive approach to the LED. And I'm convinced about it, and I can tell you a story. The story has always a big power. John Pascas, I was a fellow at Mount Sinai, as you know, and John Pascas came when I was a fellow from Emory University to Mount Sinai. And suddenly when he arrived from Emory and he was able to perform a robotic mid-cut LED, suddenly his volume in the first 3 months, like there were tons of patients that were sitting around, and we were all struggling. Like, you know, Mount Sinai is a huge value places, but all of us were the young attendings, and us fellows were always looking for CABG to do and to practice and to have. We were going to sew. There were no many CABG. Suddenly the guy comes, and there's tons of cases. And the number one referring physician of John Pascas when he was at Mount Sinai was Samin Sharma. And for you guys that are not in the US, or the guys that were not in the US, Samin Sharma is probably the number one interventional cardiologist that plays more stents than the rest of the world. So reality is that even the most aggressive stenters, even the most aggressive interventional cardiologists out there recognize the value of an hematology. And even the most aggressive people in interventional cardiology, those that you cannot convince to give you the case, and they're always like fighting to do triple vessel 3 or 4 stents. At the end, when you start to collaborate, when you start to get cases, when you start to consider hybrid, they start to bring back into the system. And then there is a huge shift that this minimal invasive has allowed me to do. I have now patients that comes to me looking for a robotic. And I can tell you, patients is always like, was seen in another institution, a major academic institution, in my city in Philadelphia, they come to me, they want a robotic. And then 50% of the time, I offer him a sternotomy, but they still come to me. They don't go back to get the sternotomy in the first center where they've been seen. Number two, even if I decided to get and we go and proceed with a robotic, and sometimes it's a robotic hybrid, 1 or 2 mammary artery robotically deployed and then a stent, you start to refer patients back to your own interventional cardiologist. Let me tell you again, you are not anymore the bird waiting for mama bird to bring you the food into your mouth, okay? Complaining because the food is never enough. Oh, you're stenting everybody, I want more here, okay? That doesn't work. You reverse completely, you shift completely the mentality. And you go to Chicago, you go and observe Sam Balky. Sam Balky is the #1 referring physician of the cath lab of the University of Chicago. Patient goes to him to have double mammary artery, triple vessel TECAB, and he gets the right done by the interventional cardiologist. The interventional cardiologist loves him. So he's a surgeon who refers to the interventional cardiologist cases. And that's changed the dynamics. And I can tell you, change the dynamics at the point that you start to see more business that are patients allocated for a better type of procedure. And sometimes are just a sternotomy bypass. A mammary or 2 mammaries, total arterial, or even 2 mammary in a vein, guys. Like, it's not that everything is total arterial here. The reality is that you change the dynamics and your relationship with the interventional cardiologist when you start to adopt a 2.0, a 3.0 level of coronary bypass grafting. And that's a shift in culture. Let me go quickly to what is TECAB. So these are some of my mid-catch, okay? And you see, these are Lita to the LED. As you see, mostly are low. I must admit, mostly are below the nipple. I have 2 above the nipple here, but mostly are below the nipple. Small incision. We try to keep it clean, nice, great surgery, okay? The problem of mid-catch is that when I see mid-catch, I see mostly an opportunity to deploy a single vessel like Lita to the LED. It's basically, the opportunity from the non-rib spreading to offer one single vessel. I say you land your helicopter on the helipad. And Lita to LED is a great option. It goes well for a lot of patients, but it's not the only thing that we are here to do. And when you start to think about multi-vessel, yes, you can do it, and we've just seen in a beautiful way, but the real holy grail is TECAB. Why is that? The problem of mid-catch when you do multi-vessel is that you, yes, keep the skin incision short, but your intercostal space underneath is pretty much open, is widely open. And pain is not irrelevant. When you do a mid-catch, to expose the lateral wall, you are always fighting with the heart, and we have heard how big is your heart, can you expose, because you need to push your lateral wall into the view that you have, like a keyhole. Did you see that light behind the keyhole in the slides before? You need to push your lateral wall coming towards you, coming into your view. TECAB completely eliminates this. TECAB allows you to move the camera of your robot going down to the OM, and your stabilizer needs only to decrease the amount of movement of your heart and decrease the amount of shifting of your heart. And then you are just completely in front of the anastomosist. Look at this anastomosist. This is looks like 2 femoral arteries. And the magnification, the quality, what you see is completely new to all of us. And so the difference is you are landing an airplane on an helipad. And if you want instead to have a complete runway, you have to go to TECAB. So this is my mojo. So I'm not here to tell you TECAB is the only way and everybody should adopt it, okay? I'm here to say adopt a minimal invasive. You have heard that there are multiple ways to cook your meal. Choose one that fits with your institution, with your way, with your skills. That is important. Message number 1. Message number 2, I'm passionate about minimal invasive coronaries, and I think TECAB has a lot to offer. For sure, we will need some extra technology. Let me tell you a couple of things. So, Second concept I want to deliver to you, and this is can be controversial, okay? But I hope you guys take it in the right way. When you look at my statistics, and Massimo Baudis is here in the first years, all of the database of everything that I do, he knows more than me what is my rate of blood transfusion. I'll tell you it's 0. He knows that it's not, and it's higher than that. But when we look how much robotic I don't do 100% robotic, I don't do 90. I do 50, probably less than that, 40. I do 60% of my cases still sternotomy. So it's still important to offer complete revascularization. But the reality is that there is a trend in literature, and these one are some of the papers, that show that when you bypass the most important LED and the most important graft on the lateral wall with 2 internal thoracic artery, you probably have done, that's the most important things you are going to do for the long-term survival. And what I'm here to say is the concept of complete revascularization in 2024, in the era of possibility of stenting, non-LED territories, complete and full medical therapy, and I'm probably going to put a vein on the right. It's probably can be shifted to I deploy 2 mammary artery inside in a TECAB way to the best target, and then if I need, I put a stent on that right. It's not for every anatomy, but a lot of patients will be treated like this. And this is a concept that fascinates me, and that's also why I'm fascinated by the robotic platform. Robotic democratized the opportunity to take 2 mammary artery in everybody's. BMI greater than 60. We have done BMI greater than 60. You can do 1 or 2 mammary arteries. Once you are in the view, you put your camera close to your rib and you can see very well. The great problems of TECAB is the lack of a stabilizer. We don't have a robotic stabilizer anymore, but we have a very good stabilizer. It's the stabilizer that comes from Medtronic and that we all use as Nuvo for minimal invasive. And together with my assistant, that is Amanda, that she's sitting here with me, we came up with this concept of incorporating free technology. So the stabilizer of Nuvo through a gel point mini that is inserted with the CO2 delivery that is provided by AirSeal. AirSeal is a technology for which you can have a thoracotomy open, but if you have AirSeal keep pumping CO2 inside the closed chest and maintain the chest completely insufflated. So this is the way in which you see the insertion looks like. This is a Nuvo mounted, you see, through a gel port mini that we insert through a 1.5 centimeters or 1.5 centimeters thin incision subxiphoid. Here is, you see the way in which that's Amanda constructing. I don't even know how to do it. She knows it. She does it while I'm taking down the mammary arteries. Here I'm the cameraman, okay? She puts all of these, you see, trocar through the gel, and those will allow, she inserted the Nuvo, let me show you the Nuvo, insertion of the Nuvo, insertion of the tip, and then taking the tubing system outside of one of these trocar, in order that everything is comes through and comes completely in the same direction. And she also put one of these saline line that can provide saline while we're doing the anastomosis. This is one of the handles that we use for clipping the mammary artery, and then we put 2 more CO2 line, 1 and 2. We sit at the robo in the meantime while she's preparing this one on the back table. I'm in the robo, you see I open posteriorly. Look how nice you see I cut the video, but you can see nicely the OM is just there, is exactly in front. And here you see the LED, comes down here, you see it, and you start to take the mammary artery. Look how you see the mammary. So the mammary is in front of you. And once you take a little bit of confidence with the robo, once you do your technique, your training, it becomes second nature. Right now, taking a mammary artery for us takes probably like from skin, from trocar positioning to mammary down is 40 minutes, 45 minutes. Double mammary arteries are 2 hours. And you know, like, We do a skin-to-skin mid-cap Geneva to LED in 2 hours. Then not always comes like this, okay? Like, because you know it, this is real surgery. So a lot of cases are more complicated. And then once we are basically in the man is down, we go at the bedside and we insert the trocar, you see, the retractor. So we do a small incision. We insert the first a dilator 8, 12, and a 15. Then we insert through the 15 the gel port. And I learned from actually the gel port rep to deploy. You see how I completely deploy the gel port inside the trocar. And then I insert the nuvo, and I close, you see, with the gel port in order to maintain isolation of the CO2. And that's it, that's mounted on the table side, and then it's provide you stability. And these are some of the anastomosis. Look at this one first. Look at this beautiful anastomosis. This is very nice, clear view, like everybody can saw this one. I can bring my 8 years old daughter to saw this one.
What's this vessel, Jennifer?
This is LED.
Oh, okay.
I want to just show you an LED. I will show you some multi-vessel tomorrow when we present, or some posterior one. But the reality is like, you know, you get to the LED and you see how nice you can have the view, how precise you can be. You can see better your target when you have those, as we said before, shitty target, shitty diagonal. You see very well. You can really explode. You can extend. You see the posterior plaque. Look at another anastomosis here. This is a different anastomosis. You see there is probably a shunt. I always shunt. I hope that the shunt is a religion, as I learned from Dr. Sergeant. So I put the shunt into the coronary, and I do the anastomosis shunted to give me the complete tranquility to have my time. You know, we are in our first period. We are doing our anastomosis time takes something that sometimes has been 15 minutes, sometimes has been 30 minutes to do an anastomosis. And you know, I'm not have any shame in saying it took me definitely longer than doing it with my own hands. But we are starting. We are in our first 20 cases. You know, so we are growing our number day by day, week by week. But it's something that is feasible and it's possible to do. Then we close and we test. And I think, you know, there is something to say.
Ellingsworth, William Ellingsworth, what do you want to say? This doc here, awesome freaking job. He did a total robotic bypass, but the left arterial appendage. And yeah, yesterday,
Left atrial appendage, of course.
I came in, all I can say is that I'm ready to go home today.
So day 1, post-op, going home. Okay? This is him a few weeks
All right, Doc,
after.
I'm feeling a lot better, brother. Thank you.
Listen to this guy. This
You
is
know, I'm a retired physician, and I very much knew what my apprehension was, my remembering of my experiences training at the Cleveland Clinic and people undergoing different surgery. And you made me feel very relaxed with our preoperative visit and with the anticipated procedure that you wanted to perform. And I felt very confident with my colleagues telling me of your abilities, and I felt very confident in going into the procedure.
What type of procedure you had? TECAB. Yeah.
5 minutes.
And
What do you think is the most difficult part? You harvest the memory, but what is the most
No, harvesting the
difficult
memory.
process?
Yeah, it's a good question. Honestly, it's just setup, as always in surgery. It's not really sewing, it's the setup. And it's making sure you pass the silastic, you are good, you have a good view, you are well stabilized. And I think that once you stabilize and you stabilize well, the anastomosis is second nature. Like, it's easy. The problem is if you are not well stabilized and things get, it's like off pump. It's the concept of the original off pump of 20 years ago. And this is like both of these guys are guys that went home in day 1. So you can offer multi-vessel, double mammary artery to the best target, day 1 they go home. Single lima to LED and a stent that I generally now don't do anymore into the same hospitalization because the patient wants to go home the same night. The same night, this patient is a physician. 26 hours, he says, I think.
how many days you have been in the hospital?
was discharged 26 hours after the procedure.
How did you felt like that?
I felt really comfortable once all the chest tubes and the arterial lines and the IJ line was removed. I felt very comfortable. I was able to walk.
And he says it later on, he says like he has a root canal that was worse than this one.
What you were telling me about the dental procedure.
Oh yeah, I've had dental extractions that were more uncomfortable than this procedure. Really, no exaggeration. If anybody's had a root canal, they know what I mean. You know,
So this is, if you have any questions, this is my concept here. Like, we have to think forward, and we need more support of technologies. We need industry to help us to make this technology going on and being able to be more facile. We need to train. That's training. We need new system to imagine new ways of making this one feasible. But at the end, I believe there is with patients that are getting older and older, if I can give you an opportunity in your hands to deploy 2 mammary arteries to the left side, I think a 40, 30, 40% of your own volume right now can potentially be diverted to this type of surgery or procedure, and that's definitely better for our patients. You know, my dad is 80 years old. If you tell him right now to take 6 months to recovery from a sternotomy CABG, he's not very happy. He's an 80 years old and goes around the world, he travels, he goes to restaurants. Like, you impact it and he starts to think, you know, what is his life expectancy? Like, the chances he will be around in 10 years is not many. If you invest 6 months out of his, let's say, ideally, let's hope 10 years of life he has ahead of him, it's not the best. That's the concept. So, hopefully you guys have enjoyed, and I'll ask Mark to close.
Questions? First, we still have Gianluca, just very quickly, please come forward. Post-op day 1 discharge, that scares me. I'll tell you, post-op day 2 scares me a lot. Because if anything happens, we are so outside of what is accepted around coronary bypass surgery, do we have a leg to stand on? I mean, these patients, you know, your patient on post-op day 2 could go AFib at 160 beats per minute, right? Yeah. And have a pressure of 62 at home. Or they could be a clip from the mammary that comes out, right? Yeah. And if you do 1,000 of those, guess what? You may have one. Yeah. And that one is going to be the, so how do you deal with it? Because I don't know the answer, and I struggle with it.
Yeah.
Sorry, before you answer this, my question goes in the same direction.
Yeah.
In Germany, cardiac surgical patients never leave the hospital until day 7 to 10.
Yeah.
So when I read or hear from you guys from the United States, it's always mentioned in papers, day 1, day 2, day 3. We think, what do we do wrong?
No.
What happens with your arrangement?
Let me tell you, let me close this one, and I probably reply to both of them. So, I grew up in Italy, okay? If, again, let's take my dad. He goes for any surgical procedure. There is no way you can convince him to go home in day 1. He paid 52% of taxes from his entire life, and when he goes to the national healthcare system, he feels that finally, you know, his government is taking care of him. So don't discharge me too early. And that's a concept that is true in Italy. I was speaking to some friends in Japan. It's the same. In Japan, you don't send home patients in day 1 or day 2. They want to stay in the hospital. So postoperative length of stay is a complete cultural, socioeconomics. It's not a marker of the quality. But the point here is like you're speeding up the process of sending them normally. You can even stay 7 days after a TECAB, and it's probably the same things, and then you send them home directly. But this guy is going to go back working, driving, and doing everything he wants within a shorter time. Day 1, it's true, I think scared me a lot, but I learned from Sam when I was in Chicago. I have an awesome nurse practitioner, and she calls these patients daily. So when you go home, and we see them in the office 5 days or 7 days, then 2 weeks, and then a month. So you maintain a very close follow-up. And I closed the cardiologist and I told them, please see him in 3 days from now. So there are eyes of physicians that goes and gets. But again, it's more of a system. You know, in the United States, we have so much push for this early discharge. But it's not a quality marker of what we do. Let me tell you that. What quality marker here again is minimal invasive in any form you have seen today. That's the type of thing you want. Sebastian.
So when you discharge at day 1 or day 2 and the patient got into AFib at day 3, what happens to him?
Okay, now I tell you more. You know, patient goes in the field because you keep them in the hospital. Let me tell you again, patient goes in the field because you keep them in the hospital. And one day I will be able to prove you that.
You're starting to sound like a conspiracy theorist.
I see Dr. Sargento like shaking his nose with his hand. Well, thank you so much, guys. No, Sargento, you have to close. Go for it, please.
With all due respect, the prevalent atrial fibrillation post-operative is a hazard function. It is well known how long it lasts. Okay, and it lasts up to 8 days, 9 days after discharge. Yes, and the point made by the audience is that there is a major risk if you send the patient home day 1, that he's going to have a very rapid atrial fibrillation at home and die from it.
No, for sure. It's also true that nowadays with your devices that you have at home, everybody has a watch or something that you can monitor. So you're entering in a new era. Everybody goes on in the other, but for sure, again, let's not focus on the discharge day 1 or day 2. The aim here is minimally invasive coronary is a tool that can help your practice to grow and to serve more patients.
Well, I think we have to move on. So thank you.